The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone, and welcome to the Academy's webinar on the CMS Professional Fee Schedule Proposed Rule for 2014. What we want to do this afternoon is to highlight some of the proposed provisions in the Medicare fee schedule for 2014. And before we get into some of the details, we want to set up what is the framework for the Medicare fee schedule, and particularly the traditional fee schedule program at this point in time. So what you have in front of you is that the Medicare payment policy and payment levels have become constrained. Carrots are turning to sticks over the next few years. Fee-for-service is moving to a value-based payment and population management. Payment policy is also moving to those that are becoming certified and organized to deliver specified bundles and packages of services. You need to plan now to participate in this change. Within your practice, that involves your decision-making, investments, and resources. External to your practice, again, your decision-making, investments, the relationships you establish, and resources that are available. This will involve and require your need to be involved in advocacy on the issues affecting home care medicine practice. The Academy is providing advocacy services on your behalf. We want to conduct some surveys, interviews of practices regarding your specific markets, in relationships to ACOs, requirements for patient-centered medical home status, and related. And you'll be hearing from us over the next weeks. Our services include advocacy, resources, webinars, and the work that's being done for the 2014 annual meeting. And these services, of course, need to be financially supported. I want to begin turn to next to a slide that we presented at the annual meeting in Dallas this prior spring that reflected the continuum complexity of care and revenue for practices that provide medical care in the home. And we see on the left-hand side, moving from traditional fee-for-service practice to more managed care types of practice, moving through complex chronic care coordination, to value-based payment modifier, and to payment reform and any future of specific Medicare networks. And then below that you see sort of also the movement from unmanaged care to managed care and to population health management, and the move of fee-for-service payment and payment for services to the rate at the lowest cost setting. And again, it's our hope that your services and your setting, of course, will benefit from this migration. What's the context, the more specific context that we find ourselves in with the release of the proposed physician fee schedule for 2014? This includes the congressional elections in 2014 and considerations for 2016, implementation of the Affordable Care Act and its obstacles and difficulties, the constraint, as we just discussed, of the traditional Medicare fee-for-service program, the end of bonus payments for certain aspects of electronic incentive programs beginning in 2014, and the start of penalties that will occur in future years. We are also now starting to see the further move of Medicare and private market shift to risk-stratified population management, global budgets, shared savings, hospital policies that penalize readmissions, and the requirement for related reporting. You're also experiencing, as others in other fields, the effects of sequestration in the current budget negotiations. That would include for Medicare the -2% on the Medicare 80% share of the Medicare allowed. So roughly overall, if you look at your allowed payments on your sites of your Medicare carriers, you're likely seeing a 1.6% reduction in those payment levels. And again, we are going to be in touch to see what's going on in your specific markets. Wanted just to touch base on the construction of the Medicare fee schedule. As many of you know, this involves the development of relative value units for specific services. That includes work RVUs, geography RVUs, and malpractice RVUs. To this is a factor of the Medicare Economic Index that evaluates the level of inflation in the healthcare sector on an ongoing basis. And this all feeds into what's known as that sustainable growth rate formula that also includes technology changes, the rate of change in beneficiary volumes, et cetera, to determine the conversion factor for the following year. If there are new or revised codes that have been developed over the year, these have to be incorporated within a concept of budget neutrality. As we know, the conversion factor, there's usually been a proposed one and then a final one, and in recent years the proposed one has been historically replaced through congressional intervention. We will post a table with house call services reflecting the payments using the 2014 proposed RVUs, but reflecting this year's conversion factor as if Congress would again intervene at the end of this year to avoid the drastic or 25 to 30% payment reductions that would occur absent congressional intervention and fixing of the sustainable growth rate. So we'll post that information shortly. Overall, just to let you know that specialties in primary care, in looking at the RVUs, would be, again, using this year's conversion factor, will experience just a flat payment level for next year, or a 1 to 2% increase, and that's again across primary care services. More specifically, in terms of the proposed rule for 2014 in the evaluation and management services, we do not see major changes for house call services. There is a list of other fee schedule services that are being reviewed, as Medicare has found that they are being paid in office settings more than ambulatory surgery centers or in the outpatient hospital setting, and they want to start to move to again make sure that services are paid at the rate at the least expensive setting. There is some opposition to the methodology that they're using to evaluate these services, and the Academy is joining in on these comments as well, and we want to make sure that there isn't anything that slows the move of appropriate and safe care into the home setting. In terms of ancillary services for the level of house call services, we don't see any major changes for house call practices. There is a change in telehealth services that we want to, we'll go into some detail. Incident to services, there's now a requirement from Medicare that incident to services conform to state law as well. Incident to is a policy of the Medicare program, and there just had not been language requiring personnel and staff rendering those services incident to physician, nurse practitioner, and PA services to conform to state law. There are changes to quality reporting programs, PQRS and e-prescription. We will go into more detail in an additional webinar on those changes. We will focus on the complex chronic care management services that are proposed for 2015, discuss the implementation of the value-based payment modifier that's being implemented depending on size of practice from 2015 to 2017. In reviewing the fee schedule proposal for next year, we do not see other major changes that specifically impact nurse practitioners and physician assistants as there was in the rule last year in 12 for effect this year, such as for portable x-ray. I want to go back and again provide a bit of a framework of what did CMS say in 2012 for this year and going forward. CMS had proposed work on an advanced primary care medical home model, and that they were working on concepts and models to support. This would include support for complex chronic care coordination, that would involve both face-to-face and also your care coordination services that are rendered on a non-face-to-face basis. And so this was an important development for the Academy membership. As we'll go into, there were new CPT codes developed for complex chronic care coordination. However, there was no Medicare coverage provided. On the other hand, there were new services, the transitional care management services, the 99495 and 99496. Those are the new CPT codes, and that coverage and payment is in effect. Related to the transition care management services, want to note in the telehealth area that the proposed rule includes payment. First, let me back up. Telehealth services have limited geographic locations and specified covered services. And generally speaking, house call locations are not one of the sites of service to which telehealth services apply. There are also specific geographic locations where telehealth services are covered by Medicare. In the proposed rule this year, those locations are going to be expanded. Currently, the current coverage is a county that's not a metropolitan statistical area or designated. Current coverage includes designated rural health professional shortage areas and sites participating in a federal telemedicine demonstration project. The proposed rule for effect next year would expand the permissible sites located in rural census tracts, such as determined by formula of the Office of Rural Health Policy, and this could also include services and locations within metropolitan statistical areas. Specifically, related to services that our members have provided, the proposal includes for effect next year that transitional care management services would be covered by telehealth, but again, if they are in the coverage areas identified. And what CMS has found is that the components of the face-to-face visit can be adequately supported and rendered by telehealth. And so they've saw fit to include for coverage next year that those services, the telehealth supported services of the face-to-face and the transition care management services would be covered services, but again, specific to the telehealth geographic locations. And we are seeking confirmation that that coverage will also include house call places of service that the beneficiary is at, and that the beneficiary does not have to be in an office location for the telehealth to occur. As mentioned, the Incident to services, CMS proposes to modify the requirements for auxiliary personnel providing services incident to the services of a physician or other practitioner. You have listed here the general requirements for Incident to services. And at present, they do not currently specify that personnel performing Incident to services meet state law requirements for performing such services. And what CMS has found is that some non-qualified personnel or non-regulated personnel have rendered services, including invasive services and procedures, on an Incident to basis. Again, there is no modifier, et cetera, that goes in on the claim forms. So CMS has found that this is an area that they want to make sure is essentially more regulated and appropriate from a safety and a regulatory perspective on a state level. And so that is becoming a requirement of their Incident to policies. Incident to services in general aren't applicable or useful from a financial perspective for house calls because that requires the direct supervision, and it wouldn't necessarily make sense for both yourself and someone rendering services incident to your services to be in the same location at the same time. However, as we discuss in the next frames, this will be important for the chronic care management services. Again, the background of the chronic care services that are proposed in this year's rule for effect 2015 have some origin to what was provided last year in terms of complex chronic care coordination codes. What CMS did last year, and to which you may have contributed to by responding to surveys and basically responding to surveys in terms of the RVU development, was to establish complex chronic care coordination CPT codes. And you see the 3 codes that are listed and the RVUs that were associated with the work that was involved in each of those codes. The AMA CPT panel approved those codes. Medicare approved those codes. They are added into the CPT manuals for this year. However, there is no coverage and payment. But that is what was done last year for effect this year. And again, we do know that the TCM codes were also established at the time and are covered this year. Organized medicine, including the Academy, believed that CMS would move forward with the chronic care coordination codes for effect this year. However, in the proposal that came out a couple of months ago for effect next year, what we have found is that instead of adopt the approved CPT codes that you see on the left-hand side, the 99487, 99488, and the add-on code for additional time, they've come out with an alternative proposal for effect 2015. And you can see that the components, the descriptor for that service is the complex chronic care management services rather than just coordination services furnished to patients with multiple complex conditions expected to last at least 12 months or until the death of the patient that placed the patient at significant risk of death, acute exacerbation, decompensation, or functional decline. And of course, as you recognize, this explains or reflects many of your patients that you see. G codes were established in the proposal to identify those services that they proposed for effect 2015 with some additional requirements that we'll talk about in a little bit more detail now. You can see the first code was for 1 or more hours of your services or that of someone working under your direction, but billed on a 90-day basis rather than on a 30-day basis, as was going to be the case for the complex chronic care coordination codes. And then a subsequent G code as well. So a comparison of what was going to be the coverage of the chronic care coordination codes versus that proposed for the complex chronic care management services. The mode for service delivery, CMS had proposed that the advanced primary care practice model would have been adopted for the 4C codes. And what they propose is a patient-centered medical home requirement or some other certification or level of approval to be determined for the chronic care coordination, complex chronic care coordination, complex care management services for 2015. The codes under the 4C were going to be CPT codes versus G codes. You see the beneficiary requirements are similar. The practice requirements, again, the more extensive patient-centered medical home requirements for the management services codes, and that also include the requirement of an NP, specific NP or PA to render the management services, and also an annual wellness visit to be conducted as sort of a marker of the primary care relationship between yourself, the practice, and the beneficiary. Claim submission under the 4C codes were going to be 1 per beneficiary every 30 days if justified. That would have involved beneficiary protections. Duplicative services would have been excluded, such as CPO and transition care management. For the proposed management services, again, we see 1 per beneficiary, but instead of the 30 days, every 90 days if justified. Beneficiary protections, again, in place, such as documentation of the change in care plan, et cetera, and that the beneficiary knows that, and they would know that there's a 20% copayment for this newly developed service. And again, duplicative services would have been excluded, such as CPO and transition care management. Payment and copayment, there was an RVU buildup on the 4C codes that, again, were expected to come into coverage and payment based on the relative value unit work that was accomplished. However, for the proposed chronic care management services, they have not, under this description that CMS proposes, that has not been evaluated nor determined, but they do say that there again would be a 20% beneficiary copayment. So what would be the practice requirements necessary if CMS adopts a patient-centered medical home or similar requirement or standards for the coverage effective 2015? And again, this is one of the key items from this webinar that to take away is where things are heading for services that, again, that we had hoped to be covered and paid for your services that you often render both on a face-to-face and a non-face-to-face basis, and that is also rendered by your staff on your behalf. Listed on the next two, this frame and the next frame, are the requirements that would be in place if CMS adopted a patient-centered medical home or similar standards. We can see that includes the requirement for an EHR that meets requirements for meaningful use, written protocols that describe methods and norms for furnishing each component of complex chronic care management provided by the practice, strategies for systematically furnishing health risk assessments to identify all beneficiaries eligible and who may be willing to participate in the chronic care management services. And again, this would be done with beneficiary agreement that needs to be documented, procedures for informing the beneficiaries and obtaining their consent, steps for monitoring the medical, functional, and social needs, system-based approaches to ensure timely delivery of recommended preventive care services. Again, this touches on the annual wellness visit approach that CMS proposes, guidelines for communicating common and anticipated issues to beneficiaries, clinical and non-clinical issues, care plans to assist with follow-up visits and managing any changes in medications, approaches to communicate and exchange clinical information across those who are involved in the care of the beneficiary, linking the practice and beneficiary with long-term services and support, systematic approaches to specific and vulnerable beneficiary populations such as racial and ethnic minorities and people with disabilities, patient education for self-management, and access to the beneficiary's EHR for those that are involved in the care of that beneficiary, and that could be supported through the EHR in remote use or through a VPN, a secure website, or a health information exchange resource. And again, that would need to be available 24/7. And then finally, as mentioned, the recognition or certification as patient-centered medical home.